ready? Well, good afternoon. I'm Leonard Weber from the Ethics Committee, and while I've had a chance to meet most of you, I think, in relationship to a council or another, I'd like to spend this opportunity to sort of talk a little bit more systematically about the role of the Ethics Committee, and to explain more fully, I think, what we try to do when we do have an Ethics Council. Also, at the end, I want to talk to you a little bit about one of the issues the Ethics Committee is working on right now, and that's the question of what should be the hospital policy in regard to resuscitation of patients with Ebola. That's an issue that a lot of people have an interest in, and the Ethics Committee was asked to make some recommendations in that regard, and we're working on that. But they're not finished, and so I'd like your thoughts on that as well. So I want to make sure we have some time for a brief discussion of that at the end. And speaking of discussion, this is a very informal kind of presentation, so make any comments you'd like at any point along the way. Don't feel like you need to wait until I stop talking, because I won't probably stop talking until 2 o'clock, unless you have a comment that you'd like to make. So ethics committees have been around for a while. Most of the hospitals established ethics committees in the 1980s. And Al, I don't know when Henry Ford did, but I suspect it was in that decade as well. And so they've been in existence for quite some time, and they've been continuing to grow and evolve in terms of their responsibilities. But there have always been 3 major responsibilities that fall under the aegis of the Ethics Committee. And that is these 3. The education sort of thing I'm doing right now, policy review and development. That's what we're asked to do in regard to the Ebola question. To give advice, we don't make policy, we make recommendations in regard to policy. And consultation. And I'd like to start talking about consultation first, because that's probably where most of you would meet us in your day-to-day life, is in a consult from the MICU or someplace like that. We actually get more consult requests from intensive care than from any other section of the hospital, which probably doesn't surprise you, I would guess. So if we're talking about consultations, our role as an ethics committee is that our ethics council role is optional. It's optional for you or anybody to ask for an ethics council, and it's optional for you to accept the advice that we might offer when we do consult. Most of the time, it's optional, and most of the time, it's optional on the other end. But generally, that's our model, and I'll talk about the exception a little bit later. That's very different from some other kinds of ethics committees, just so you can put it in a framework here. If you have a research ethics committee, an IRB, that's mandatory model. It's mandatory to take your research proposal involving human subjects to the IRB before you can proceed, and it's mandatory to get their approval before you can proceed. So it's a quite different model. And while it sounds as though optional is a weak model, in the sense that everybody's free to say, like your help, or no, don't want your help, it's not quite that simple. It's actually, in terms of consequences, my sort of informal observation over a lot of years of being involved in this is that our advice is followed much more often than it is not. And so it's a role that we take very, very seriously, because even though it's, quote, only advisory, we almost always have a significant impact on the issues that we address. Anyone involved can request, in the patient's care, can request a consult. Most of the consults that we get come from physicians, but they can come from others as well. They can come from nurses, they can come from mid-level providers, they can come from patients themselves, they can come from families or guardians. Anyone of that sort can request an ethics consult. And when we do get an ethics consult, this is the other side. It makes it a little bit more clear, maybe, if I make it this way. No one can veto an ethics consult. So if we get a consult request from a nurse and the attending says, I really don't think we need an ethics consult, our response is, but we have a responsibility to follow up on this to see what's going on and to do our best to try to help, because we have a request. It may mean in the process it'll be resolved, but nevertheless we don't get somebody who didn't request a consult can't cancel. Any questions so far? Any thoughts? All right. So if you look back over 30 plus years of ethics consults in most major hospitals, you can find this kind of a pattern usually. There's been a consistent characteristic. That is, more than half of the consults have always been cases near the end of life. And they've always been cases in which there's been some difference of opinion. Usually between, sometimes among the staff themselves, but usually between the treating physicians and whoever is speaking for the patient, usually the family. So that's been sort of a constant. What has changed over the years is the nature of that disagreement. 30 years ago, the majority of the cases were cases in which the physicians wanted to continue, and the patients or the families said, enough is enough. It's time to stop. Again, usually it wasn't the patient, it was whoever was speaking for the patients. Now, majority of the cases, not all, but the majority of the cases are cases in which physicians are saying, this doesn't make any good medical sense anymore, it's time to stop, and the family or whoever is speaking for the patient is saying, we're not ready to. As long as there's life, there's hope, or some such comment as that. So what do you think has changed over that period of time? How would you account for that? Again, what has changed in the nature of the consult requests that ethics committees get is who wants the more aggressive form of treatment. In the past, the cases that came to us were more that the physicians wanted to continue and the family or patients were saying no. Still get some of those. A fairly significant minority, but they're definitely a minority now. Majority now are cases in which the physicians are saying it's time to stop and the families are saying no. What do you think has changed?
Glorification on TV and the media about the saves.
Could be.
Yeah.
It could be the expectation on the part of families that hospitals can work miracles, and when you can't work miracles, they're still expected. Maybe, I think though in another way, that's part of it, but the other side, I think physicians have changed. I think education of physicians has changed, and as well as the recognition that the technology that you use sometimes doesn't achieve the goals that people can point to. Families have always been mixed. You have some families now who want to stop, obviously, and you have some who want to go on. 30 years ago, that was the same. Some had on one side, some on the other. But I think physicians are much more likely to recognize, as part of the changing education, I think, much more likely to recognize the limits of what you can do in some cases. You might be able to produce, as some people talk about, an effect through the use of an intervention, but an effect is not necessarily a benefit. And so recognizing that you've got to take the bigger picture into account, where are we going on this case becomes a question that's asked more frequently of physicians, by physicians than it is sometimes by families. Anyway, that's my perception of that anyway, and there might be other explanations, but that reality has changed somewhat. So when we get a request, we follow up right away, at least in terms of the initial phone call, and try to get a sense of what the issue is all about. And what we try to do then is to see how we should respond. And that varies somewhat upon the nature of the case. So one of the first questions we ask is it urgent? And usually they'll say, well, soon, but not so urgent that we need to have a thorough discussion with you before lunch. But, but that's a question. Sometimes it is urgent. Sometimes in those cases we can only usually respond on the phone. That's not the ideal, but sometimes there is no choice. I'm usually the one who does that initial callback. Not always. There are other people on the ethics committee who do some of them. And in that initial callback, we try to begin that sorting out process of what's the best way to respond. And again, try to avoid an individual phone response. That's not the ideal kind of ethics consult. What we want to do is to have a more thorough review of the situation and then offer our advice. Remember, we're coming in cold. We don't know the situation. And that's part of the reason why you call ethics, is because you want somebody who hasn't been deeply involved in this case, hasn't been part of any disagreement that's been taking place, You want somebody who is sort of a neutral third party, if you could use that term, to review the situation and see what can help. The other reason you often want an ethics consult is you want to clarify what the options are under institutional policy. And that's also part of the role of ethics committee, is to clarify what you can do according to the policy and what might be limits on what you can do according to the policy. So that's one of the functions, and of course our committee is also involved in reviewing and revising those policies on the basis of the best ethical standards that we are familiar with. So we usually then try to say, who are the relevant stakeholders in this case? Who do we need to meet with in order to understand how to respond to the question that we're being asked? If the question is being asked, do we have to do CPR when the family wants it, in this case, who do we need to meet with? Well, usually what we need to meet with, that sounds like, initially anyway, that sounds like a question of saying there's no medical benefit to this. And if the question is asked from a physician, that's usually what it means. So we need to meet with the physician team in order to assess why they're saying, to understand why they're saying there's no medical benefit. We don't yet need to meet with the family, because the question is, are we supporting the position that there's no medical benefit? And the family is not going to be able to assist in that. If, on the other hand, and this is the minority of the cases, but they come up, if, on the other hand, there is a question about whether the spokesperson is representing the patient's wishes appropriately, because there might be an advance directive that seems to indicate one thing, and the patient surrogate is saying something else, then of course we do need to meet with the family. So part of our sorting out right from the beginning is clarifying who are the stakeholders, who are the persons necessary for us to meet with in order to understand how best to respond to this question. And so then we arrange that meeting, and at the meeting our primary responsibility, sometimes at the meeting the agreement is reached, but more often, oh, how did I get to Ebola? What we're involved in the meetings is fact gathering. And in that sense, what we're trying to do is we ask a lot of questions. We rarely sort of offer our immediate solutions or recommendations or advice. What we do is ask questions about, why do you think this is not beneficial? What's your prognosis if you do this? What's your prognosis if you don't do this? What's your long-term expectation? And some other factors involved regarding the family's perspective on this, and what kind of conversations have taken place with the family. What have they been led to believe? And most important of all, what have the options that have been presented to them been? It's sometimes people will contact the ethics committee and say the family is unrealistic, and we investigate. We might find out, well, what the family is saying is, yes, we would like to have this treatment that you talked about. Well, if you talked about it, it's not unreasonable for the family to think that that's an option, unless you talked about it in the sense of ruling it out. But a lot of times people would say, well, we could do such and such, when they really don't mean to say that's a realistic option. They just mean that somewhere on the perspective of things that we talked about or thought about, that was there. But it's not unreasonable for family to read that as saying this is on the table as an option, and so I would like that. So part of the whole question is what is being presented. If something is not presented as an option in the sense that it doesn't make medical sense, that's different than from presenting something and saying, do you want it? This then becomes a question of, we are not going to be doing this because, as opposed to, should we do it? Understand? So that's a part of the question too, is clarifying all of that. So what we want to do then, after we've gathered the facts, is we often will excuse the people who are the stakeholders in the case, so we can deliberate briefly among ourselves, and then provide a recommendation or a set of recommendations, which then you can choose to accept or not to accept. It's a process which it's not easily described in some ways, but when you see it functioning, it can go pretty smoothly and pretty quickly. Ordinarily, we will have a recommendation shortly after our meeting. Sometimes we will need to have a second meeting, follow up something with different people or with the same people, but usually not. Questions on the consultation process? Okay. Now this is what I hope again I don't jump too fast. How did that happen again? Somebody have a insight into what I'm doing wrong here?
Is that what wire and
That's a later section. I want to go back up.
is this how?
This way.
That's going back.
That's what I want to do. I want to go back.
Yeah.
This jumped ahead. Okay. Are you putting my hands on there? Is that the problem?
Yeah.
Okay. All right. So over the years, there have been the evolution and clarification of a lot of the basic ethical standards that the ethics committees use around the country. And we use these in policy, we use these in education, and we use these in individual cases. And I'd like to go over a few of those with you right now. So we talked both about the nature of physician responsibility and the nature and limits of patients' rights. Patients' rights has often gotten a lot of attention in clinical ethics. And that's understandable, I think, if you recognize the history. This contemporary movement in medical ethics started about 1970. And that is coming out of the 60s, obviously. And coming out of the 60s, there was a strong emphasis on we don't want any paternalistic behavior. We don't want somebody telling us what's the right thing to do for ourselves. So patient rights was the emphasis. And the initial emphasis was on the right to say no to unwanted treatment. And there was a lot of that. The right, therefore, to have information so you can make an informed decision about whether you wanted that treatment, and so on and so on. And so there was a lot of emphasis on patient rights. Over the years, I started adding that other term in there, the nature and limits of patients' rights. The limits, because it becomes increasingly clear that while they have a right to say no to unwanted treatment, and they have a right to confidentiality, and they have a right to information necessary to make decisions, they don't have a right to tell professionals how to exercise their responsibilities. There's a difference between a patient's role and a physician's role. And so that's part of the limits. And that's what I think is a lot of what we're wrestling with today is whose decision is it? Is this a decision that, quote, belongs to the physician? Is this a decision that belongs to the patient who's speaking, whoever is speaking for the patient? And so that's part of what we're going to do is in our consults is to try to figure that out. Here we go again. Anyway, we will continue our efforts.
Computer is anxious to get us there.
The computer is very eager to get there, and maybe one of these times we're just going to say, computer, you win. Let's talk about Ebola, but not quite yet.
Where will we now?
You're back to number 2, right there. That's it, number 1. Okay, number 1.
I guess you can press this one like from on.
Yeah.
So next slide would be that one.
Yeah, that's what I've been doing, but it jumps. Okay. So physicians and patients have different roles. Physicians' responsibility is this way, to decide what treatment should be recommended and offered based on available evidence and patient's clinical conditions, and patients and surrogate have the responsibility to accept or decline. Very straightforward, very important, but amazingly difficult in some cases for people to clarify what's what. And so to help clarify it, not for physicians to exercise the patient or the surrogate role, for example, decide whether a proposed treatment plan is acceptable to the patient. That's the patient's role. Again, this is simple in concept, but this is what is often at the bottom of an issue. It's not for patients, on the other hand, to exercise the physician role to specify the types of treatment that should be included as medically appropriate. So if somebody says to a patient, if your heart stops, do you want us to do CPR? Whose decision is it? You've just made it the patient's decision by asking, do you want? Because the implication in there is that it is an appropriate form of treatment, otherwise you wouldn't ask, right? If you ask, you're saying to the patient or the family, this is your call. It's code status determination is one of the most difficult things to do well, and it's often behind a lot of the problems that we face in ethics consults. If a physician says, I don't know a good example right now, so I'll come back to that. So physicians have a responsibility to accept the decision on the part of the informed patient, or the surrogate decision maker, appropriate surrogate decision maker, to decline unwanted treatment regardless of how strongly the physician wants it done. I've been involved in a number of cases, mostly at other institutions, where this has been the heart of the matter. A physician said, but the patient isn't dying. This is reversible. And the patient surrogate said, but she would not want this. And how do you handle those cases? Well, the underlying principle is that if the patient has a right to say no to unwanted treatment. But do you really know, when you have a surrogate decision maker, that the patient doesn't want this particular treatment? So many times in those cases, we meet with the family or whoever's speaking for the patient, and if they say, patient would not want to be kept alive in these circumstances. I'm thinking of one example right now of a patient who had an automobile accident, and he was recuperating slowly from the automobile accident, a lot of complications following surgery. He was in the ICU, and the prognosis was that he had a good chance, 50-50 chance perhaps, maybe better, of surviving, going through rehab, and ending up a functional, wheelchair-bound paraplegic. And the spouse said he wouldn't want this. He wouldn't want to be kept alive with that prognosis. Now, the physician has a responsibility to accept a legitimate declining of treatment, even if the physician thinks it's a bad choice. But the question often is, and the reason we were involved in that case, the question is that really what the patient wants? What's the evidence that that's the patient's own wishes? Because it's being communicated by somebody else. And so you begin to search for the basis for that. Why are you saying that? Is there an advance directive, first of all? And if there is, what is the wording in the advance directive? And who chose that wording? And what was the conversation surrounding that wording and so forth? If there's not an advance directive, then what are you basing this judgment on? Have you had this conversation explicitly? If you hadn't had an explicit conversation, what's the indirect evidence that you have? What about other members of your family? Have they had conversations with the patient, etc.? So it's trying to get at, because what you want to do is respect the legitimate decision on the part of the patient or himself or herself not to accept treatment that they don't want. That's our ethical responsibility, to accept that decision. But that what they want or don't want is not always easy to get at. Sometimes it's very difficult to get at when they are in a situation where they can't speak for themselves, where they can't understand the situation. So that's trying to get at the question of accepting the decision on the part of the patient not to accept treatment regardless of how much it's recommended. The classical case there, of course, is always the Jehovah's Witness case. Blood transfusion is something that often is beneficial. It would be, if it's beneficial in a particular case, you can recommend it, you can propose it, you can't enforce it, you can't force the patient to have it if they are adults who make the decision for themselves not to have it. If they can't speak for themselves, somebody has to speak for them, but then again, you can ask for evidence of why they would not want it. Don't have to be Jehovah's Witnesses, of course. You could be somebody else who didn't want blood transfusion, but the Jehovah's Witness case is the one that we usually think about. Working a little bit better. So patients and surrogate, on the other hand, should not receive treatment interventions that physicians have judged medically non-beneficial, no matter how strongly they, that is the patients or surrogates, want it. A lot of times I hear conversations from people working in an ICU, dealing with the question of treatment decisions near the end of life, code status decisions. They're saying, you know, why can't it be like surgery? Surgery, you can simply say, you're not a candidate for surgery, end of question. But if we say, you know, CPR is not indicated, it isn't the end of the question. What's the difference? Is there a difference?
surgeons go more with benefit versus risk. Like they say, not a surgical candidate, chance of patient dying on the ward table is too high to even go there.
Well, yes, I mean, that's true. They're the basis for which they make that decision, and they're not to make that judgment arbitrarily, but on the basis of the evidence available to them, of course. But you could have evidence available to you just as well that in patients of this sort, patients with this disease progressing to this stage, the evidence is clear that they will not recover to the point of being, if CPR is attempted, to the point of being discharged successfully from the hospital. They will die in the hospital, 99% of the cases or whatever it might be. Surgeons go on smaller figures than that. You rule out surgery. Why can't you rule out CPR? Well, you can. But it's harder because the social and cultural expectations are different near the end of life. There's an expectation in our culture that the question about whether resuscitation should be attempted is a patient's call, not a physician's call. And ethics committees have been working for 30 years in saying, sometimes, how do we distinguish from the situation in which it is the patient's call from those in which it is not the patient's call? And how do you determine what's beneficial at that point in time? And so a lot of times, that's part of our role is to try to address those questions and help. So Henry Ford has a policy, like a lot of hospitals have policies now, which allow physicians to write do not resuscitate orders, DNAR orders, without the agreement of the patient or the surrogate. At Henry Ford, it's only without the agreement of the surrogate at present, but we're working on revising that policy a little bit too. So without the agreement of the surrogate, when is it appropriate to write those orders without the agreement of the surrogate? Only when there is good evidence that it is not beneficial. So it's like the surgery question. When there's good evidence that this is not going to help the patient, or that there's more risk than harm, more harm than benefit. And this is one of those cases, I'll get you in a second. This is one of those cases in which ethics consultation is required. It's not optional. Because whether the policy in this institution is written in such a way that in order to implement that policy, you have to have the concurrence of the ethics consultation. We don't make a medical judgment that is non-beneficial, but our role is to assure that you're making that decision on the basis of a medical judgment, not on the basis of something else. Because what we want to be able to assure the family and the public and ourselves is that this is a decision based upon good medical practice, not on anything else.
Would you take whatever the ethics committee recommended as like delegation from the family? Would you
Is what? I'm sorry.
If the family sues the doctor for making MDNR, what evidence can the doctor, whatever the ethics committee recommended, can be used in terms of saying, yeah, we have evidence, because it's one physician, you can have 20 other physicians to say, well, I would have done that differently than.
One of the first things we do on those cases is say, are all of you in agreement? All the physicians are actively involved in declaring this patient in agreement. Just because it isn't a clear sign that this is not beneficial if only one physician is willing to take that position. So yeah, you're absolutely right. So that's part of our role, is to see whether this is a shared medical judgment. And the policy requires 2 signatures for 2 different senior level physicians, as well as a concurrent signature by the ethics consultant. But the important part is that it is a shared medical judgment that this, in this case, is not beneficial. Because you're absolutely right. You don't want to just, because there is an expectation in our society that you want to have every possible effort to maintain life, if that's what the patient wants, then the bias, the default, whatever you want to say, is in favor of doing it. So going against that requires quite a bit of evidence. But the evidence that we look to is not necessarily published evidence, because that we assume, what we look to, because we assume physicians are familiar with that, what we look to is whether there's shared agreement among physicians that in this case it makes no medical sense. Okay, so so again, trying to separate the roles. So as I often think about after the end of a consult, what all we did here was sort out who's making what kind of decision. And that's why I made that comment earlier. So a decision that treatment should be withheld or withdrawn because of the patient's quality of life is ordinarily a decision that goes with the patient, not with the physician. Because medical benefit is usually removed from whether it is worth it to the patient to live that way. You know, the case I just described to you about the individual who was injured in an automobile accident, the spouse was saying he wouldn't want to live with that quality of life. She didn't use those terms, but that's in effect what she was saying. He wouldn't want to live with that quality of life. That's appropriate. For a patient to say it's not worth it. What matters most to me is something else. But for a physician to decide that the quality of life of this patient means I shouldn't do it, or I should withhold it, or discontinue it, or whatever, is a little different. That is not the primary focus of medical treatment, is the quality of life judgment. I say a little different, and I use a qualifier here ordinarily, because it's hard sometimes to draw a firm line between what a quality of life judgment and a medical benefit judgment. But generally speaking, when it gets into the area of quality of life, is it worth it? Would a patient want to live in these situations, with this condition, with these handicaps, anything like that? That's a question that we don't want physicians to decide for patients. We want for patients or their representatives to decide for themselves. A lot of times families will say, I want everything done. And how do you understand everything? This is the recommendation that we bring to these cases. Everything means everything that has a reasonable chance of providing medical benefit, or my favorite is these 5 words, everything that is consistent with sound medical practice. Consistent with sound medical practice. Sometimes in advanced directives, people have boxes to check what they want, and one box, the most aggressive treatment wanted, is usually I want everything done. Some advanced directives, and these are the ones that I always advocate for, some advanced directives have this phrase in there. I want everything done, comma, consistent with sound medical practice. And that makes good sense, because then you're recognizing anything that is reasonable from a medical perspective, I want. And that's a legitimate choice on the part of the patient. What's not a legitimate choice, ethically speaking, is wanting everything done regardless of whether it has any chance of being successful or not. And so that's why I say it does not mean everything that is technically possible. There's no ethical justification for doing futile treatment. And not all conversations about treatment near the end of life should be conducted in exactly the same way. When you're talking to a patient or family about code status, my thinking is, and recommendation is, before you have that conversation, make sure you understand what the patient's condition and prognosis is to the best extent possible at this point in time. Because if CPR is reasonable, then you offer it. If it's not reasonable, you don't offer it. I'd like to, if you're not familiar with this, I'd like to call this article to your attention, and again, it jumped. But I think I can fix it. This article. I think what happens is I hold it down too long, and so it jumps to the end. Time to revise the approach to determining cardiopulmonary resuscitation status from 2012, JAMA. What the authors are suggesting that there are 3 different approaches depending upon the situation. In some case, you do present it as an option, which is entirely up to the patient or whoever's speaking to the patient to say yes or no to. But those are only the cases where it is really likely to provide benefit, or there's a good chance it will provide benefit. When a patient's disease progresses to the point where it is not likely to benefit, but it still might, that's the second position. In that case, they suggest that you recommend against it. You don't say, do you want CPR? you'd say, because of this condition, it is rarely beneficial to do CPR, and so we would like to write a no CPR order. That's our recommendation. But because it's a recommendation, you're still leaving it up to them to say yes or no. And the only you can do that if there is some potential that it could be beneficial. The third situation is where the patient is dying, it's irreversible, there is no way in which CPR would stop the dying, except temporarily, if that. In that case, you simply inform the patient's surrogate that CPR is not indicated, it will not be done in this case. If they object, you have to go through the policy. But they don't always object in that case. If they object, then we have you have the possibility of doing it without their agreement. But agreement can be, in this kind of a case where you're informing them what you're not doing because it's not beneficial, agreement can be silent. Agreement can be an assent, but they're not objecting. And that's sufficient agreement if it is presented consistently as not beneficial. What often happens, of course, is the first time you talk about code status, it is an option. And so that, it's presented as an option. So another recommendation is to think the very first time, say, sometimes it is helpful to do resuscitation. And if it is likely to be successful or beneficial, do you want it done? If there's likely to be some benefit from it, do you want it done? But because you phrase it in that qualifier, sometimes and if, next time you come back, if the medical situation, the clinical situation has changed, it's easier then to say, we've reached the point where it's not going to be effective. It's not going to be beneficial. And so we've reached the point where we have to change the code status. And they're somewhat prepared for it because you have right from the beginning talked about it as not something that's always done if you want it, but it's a combination of two things that makes it to be done. You want it, and it provides some benefit. If either one of those is missing, it shouldn't be done. So if you don't want it, it won't be done. And if it doesn't provide any benefit, it won't be done. But either one of those independently can mean no, but you have to have two together to mean yes. All right, and just one last comment on our general guidelines before we talk about Ebola, which the computer wants us to do. A lot of times people will say, one of the difficulties in these discussions is that the religious beliefs of the family are so strong, or that they come from a culture which expects certain things and different from the medical culture here. How do you handle that? Well, I think one way of thinking about that is that that's very important to respect as a factor that is influencing the family and the patient and their desires about what kind of treatment they would want. But that it has no implication for your medical judgment. Your medical judgment should be the same about whether this is likely to provide benefit. It should be the same for a person who wants everything done, for a culture that says we believe that any life is good life, no matter how minimal it is, or for a culture that is very different and says, I don't want to live if it's not a high quality life. Neither case should affect your medical judgment. And so I think that's where we get confused again about whose decision is it? Well, you still present the same medical facts, the same medical prognosis, the same medical justification or lack of a justification for an intervention, and they still present their point of view based upon their own beliefs and values, but one doesn't substitute for the other, or one that shouldn't influence the other. Comment?
In my years of being on ethics committees at different hospitals and places, the hospital administrators, the attorneys, and other folks want us to be held hostage to this faith-based, cultural-based phenomenon of beliefs. Oh yeah, that's fine, but remember they're this, they're that, and so we can't afford.
Yeah, this is really one of the more difficult areas because a lot of people think that sensitivity to the culture and respect for a culture means that you change your practices in relationship to the people of that culture. That's a failure, I think, that we slip into very easily. There are a couple ways in which the faith-based culture makes a difference. If you're working in a faith-based organization, if you're working for a Catholic hospital, for example, Catholic hospital has a set of beliefs which they definitely want to influence some of these decisions. But that's not what we're talking about here. And so I was, so when you're apart from that, you can respect somebody and respect their judgment, just like you can respect my judgments and say, I'm not a Jehovah's Witness, but I don't want a blood transfusion. You might not understand that. You might not agree with it. But it shouldn't change your judgment about whether a blood transfusion would be appropriate for me or not. In the same way, if somebody says, I'm an Orthodox Jew, and my belief is that we keep life going as long as possible, regardless of the expectations of recovery, that shouldn't change your view about what's medically appropriate in those circumstances. And so it's just recognizing that respect for religious views, for cultural diversity, means respecting the individuals who hold those points of view and letting that appropriately influence their judgment when they're making decisions about what's their decision. But it doesn't mean that you should change your behavior. The organization sometimes is overly sensitive, any organization is overly sensitive, as Dr. Bowles just said, to that because of publicity considerations, I think, mostly, reputational situations. But that's not for the individual patient care decision to be influenced by that. Okay. As I said before, yes?
I have a question on the
Sure.
process, how it goes. So we call ethics to get involved, and you guys
We come and respond, yeah.
and respond. And then, I mean, the decision is it made you guys, so who meets, or is this decision based on one or two, and I mean, is it different disciplines that sit and meet, or I mean, based on what you guys come up with, is it a decision?
Yeah, we try to respond with a core team. So I'm usually the leader of the group, but there are 2 or 3 of us, usually beside myself, so 3 or 4 total. From the ethics team who've had some training and experience in dealing with these. And so what we do again is we try to clarify our understanding of what the issues are all about. What's at stake here, what's the core difference of opinion, and so forth. And then we try to point forward a solution which is respectful of those ethical principles that I just reviewed. Because that's our role. We aren't there to try to, we're not an advocate for the family, we're not an advocate for you. We are or for the institution, except for the institutional's commitment to having good ethics. And so good ethics is what we're committed to. And I usually find that people say, how do you know good ethics? People have different points of view. Well, there is sort of a standard around the country on almost all these issues about how to resolve them. What's the appropriate way to resolve them? There are books written, most of which are in agreement about this. There's some variation, but in most cases, there's clear agreement. If we have any doubt, and yet the individual consults, we then review later in part of a larger committee to see if we have perhaps too quickly reached a judgment or something like that, what we can learn from this case for the next one, something of that nature. And if we have any real concerns, our quality control mechanism would be to go to other people outside the institutions who work in ethics, see how they would resolve this case. We would present it confidentially, of course, but how would they resolve this case? So comparing our ethical perspectives to those of others. We still might miss something on an individual case. We might have got the wrong picture somehow. In which case, you might not want to accept our judgment, our recommendation. And that's your prerogative. That's why we are an advisory committee. Because sometimes we can get it wrong, especially getting it wrong in terms of understanding what's going on there. We don't usually get it very wrong, I think, in terms of the basic principles of ethics. But I think we could get it wrong in terms of understanding the realities of this case. In which case, it's your responsibility to say, let's talk about this further, or thank you, but I think this has been helpful, at least in the sense I know what I don't want to do now. Something along those lines. So again, that's why we don't feel hurt if somebody doesn't accept our advice, because we know that we are as an outsider group, we have the potential for missing something. We try not to do that. That's why we take it very seriously. Our fact-finding role, our questioning of people, to try to get a clear picture, and we always review the chart and so forth to get that picture as well. Other questions?
What I found troubling in ask my opportunities is that some of the caregivers would say, or would think this, or even say this, that someone would call for an ethics counsel, not the attending physician. So they would not even want to even hear the opinion to consider it as a possibility. So they would say or do, I don't care what they say or do, this is the way it's going to be. So we're done. So the one time when they had me to be the chair of the committee, I'd say, well, Dr. Conway, there's got to be, for me to do this, I need to be able to tell some doctors when they're the doctor in charge, I'm just not coming. It's not going to come because you have no chance to even deliberate. So, and I know who they were, and so he said, okay, you can do that.
Yeah.
There's only a handful, about 5 or 6 physicians in this institution that would do that. And we don't need to be involved in that. But I could go and teach the others who want to learn that about how we would approach it ordinarily, but not do a formal thing in terms of that kind of thing.
Yeah, and I usually try to give the impression, and not just impression, but my understanding of reality is, as I said earlier, no one has a right to veto a request, and that we will follow up, regardless of who objects to the fact that somebody else.
Right, I mean, they wouldn't veto, but they would just say that we don't care what you say.
Well, that's a veto.
Yeah, basically. You waste your time.
And so what we would, so we go in with the expectation that they're going to fully cooperate, that they're going to show up for the meeting, and almost always it works, especially if we have the cooperation of the rest of the team. Because a lot of times we'll meet, and somebody will say, well, where's so-and-so? Can you page them? And if they're paged, look, the meeting is taking place right now, we need you there, they usually come. And so it's you're right, some people are going to resist it. But I think as time goes on, there's less and less resistance to the role of an ethics consult. Because if we do it right, we're helpful. If we don't, and we don't enforce it or anything of that sort. And so, to me, there's a long debate in the ethics consultation about whether it's good to have more or to have fewer consults. If you have fewer, maybe that means that people know how to resolve it themselves. If you have more, it means that people are taking advantage of the service and maybe doing a better job, quality of care, because they're thinking it through systematically. I guess I'm on the side of it's better to have more, because I think that's a sign that people are seeking help, because there are always going to be some difficult cases. No matter how well you learn the basic approach, there's always going to be some difficult cases. And in the last few months, I've been noticing a trend upward in the number of consults that we've been having, so maybe we're doing okay. All right, other comments or questions? So we're now talking about this issue. We're not yet ready to make any recommendations, but we have identified, I think, a couple of key considerations. So the question that we're being asked, this is oversimplifying it, but it's basically about whether all patients with Ebola can be grouped into a category and all considered DNAR patients. So it's not resolving the issues on a case-by-case basis, which you do now, but on a diagnosis basis. All right, that's a big step if we do that. And I think there are two reasons. If you look at what people are talking about, there are two reasons for doing this. One is that the increased risk to the staff. If you attempt CPR on a patient that's bleeding at the end of Ebola, that's risky to the people who are doing it. The other consideration is also not likely to be beneficial. Okay, which of these, if either, makes the most sense? So if we go back to our current policy is that you can do a DNAR, because what we're talking about in those cases is doing it without the agreement of the patient or family, doing it by diagnosis, not by conversation with the people. All right, now, our current policy, as I said, permits DNAR order without the agreement of the surrogate, but only on a case-by-case basis and only with the concurrence of the Ethics Consult Service. So to assign all patients in a certain category to this status would be a big step different, and so we want to make sure that we think it through carefully, and that's why they asked the Ethics Committee for a recommendation in that regard. So one of the considerations that we are taking seriously is this: if there's clear evidence that given the nature of the disease, attempted CPR would not provide benefit for these patients, or qualifier if maybe only after they've reached a certain stage in development of the disease and the progress of the disease. And that's not something that we can answer. That's a matter of what's the evidence out there indicate to the people who are doing the research about how the disease progresses. But if there is evidence, this is the ethical guideline, then if there is evidence that it would not provide benefits to patients with Ebola who arrest, then there would be ethical support for DNAR without agreement on the part of the patient or the surrogate based on the fact of no medical benefit. As I said earlier, there is no reason, no ethical justification for doing non-beneficial treatment. The risk consideration can strengthen that rationale, provide additional rationale if you want, but it's not necessary. Just the fact alone that it is not beneficial would be sufficient reason to do it. So the question that we will be posing, if we take this route, to the infectious disease experts is to say, what's the evidence? Does it fit this category? That patients with Ebola, or patients with Ebola who reach the exsanguination stage, or whatever it might be, are universally irreversible, regardless of CPR attempt. If that's the case, obviously not all Ebola patients are going to die. We know that. Some recover. So if there's a state at which it becomes clear they're not going to recover, that is sufficient reason. I think the Ethics Committee will probably argue, we're not finished our deliberations yet, but we'll probably argue for saying that's the point at which they should do DNAR. Not let up to them whether they want it or not, but based on the lack of medical benefit. Does that make sense to you? And what I'm trying to do here is to separate out the two different considerations. The risk to the staff is a very important consideration, but this is probably the more important consideration of whether it's going to benefit the patient, because the whole purpose of treating patients is to benefit them. And if you're not going to benefit, yes.
Is that the stance other ethics committees and other institutions have taken for Ebola?
It appears to be. It's very, very difficult to get information from other institutions about how they're treating this question. But all the evidence that we've been able to get so far is yes, this way. What I'm not able to answer to you yet, or to anybody else, is whether they're doing that immediately after the diagnosis has been confirmed that this is Ebola, or only if it's progressed to a certain stage. But I don't, there have been 2 patients that have died so far in this country from Ebola, and to the best of my knowledge, but again, this information is very difficult to get, but to the best of my knowledge, CPR was not attempted on either. But I'm not positive of that.
We almost had this situation come up when the AIDS epidemic. Certain forms of outbreak, they're going to take care of AIDS patients,
right?
And blah, 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 blah. And I remember reading an article in, I think it was JAMA, that went way back to, I think it was Borkos or something like that, that said something of this nature. Any man that takes into a profession takes all the good and the bad. Because if you're a captain in the army, you might have to fight.
Right.
You just got to preach.
And that was,
got to take care of the sick.
yeah, you and I are both old enough to remember the whole discussion about AIDS.
Yes.
And there were some of the same issues were raised there. And the ethical standards that went out, so to speak, was that the risk to the physician, to the nurses, and to the others who are providing these interventions should not be the deciding factor. That's the same thing we're saying here, I think. That's not the deciding factor. The deciding factor is whether it's beneficial or not. And so if you then go to the question of risk, if there's reasonable expectation of benefit for the patient, risk alone should not be enough reason to not do it, unless you're not properly trained. I mean, so there's an institutional responsibility to make sure that people who are asked to treat these patients are properly trained and outfitted so that they are protected to the extent possible, not 100%, in all likelihood, but to the extent possible. But then they should also be expected to provide the care, if it's reasonable. Because as you just indicated, Dr. Bowles, this is part of what goes along with the professional obligations, is to take some risks, reasonable risks, not unreasonable ones, and that's why the qualifier makes that they have to be trained and all that, but reasonable risks in the pursuit of good patient care. And so that's why I think it's helpful to sort out the two rationales. So a lot of times people say, we shouldn't do CPR because it's too risky. I'd like to say, well, let's start with the question of, is it likely to be beneficial? If it's not beneficial, then you certainly shouldn't do it. If it might be, because a reasonable expectation of benefit so that you would do it in similar patients with similar outcome expectations without, but this is a riskier one. Risk alone should not be a reason not to do it. Does that make sense to you? As I said, we're not finalizing this recommendation yet, but that's the inclination that we have in approaching this. It is easy to think in the media, this discussion of this and a lot of the popular discussion of this, it's easy to think that the primary consideration is risk. And I think that that's fine if that then leads to making sure that people are protected when they're providing care. And that's good, that's essential, and that's an institutional responsibility. But if they are to the state of the art protected, then to expect them to treat, even though there may be some risk, is I think ethically reasonable. Thoughts? Yeah.
I have another question about, hypothetically speaking, if Henry Ford institution would make policy that his patients would both with DNR, is there an ethical responsibility to let our community counterparts be aware of that policy?
And who would that be? The public or the other institutions or what?
Other institutions, the public, so that in the event that, we have a case like this and the patient could be potentially transferred to our institution, they're aware of the fact that if you start to crash, you will not be performing CPR. Is there an ethical responsibility to make people aware of that policy?
I think that there is in general. I don't know exactly how to implement that, but in general I would agree that you should not hide your policies, pretend they are different than they really are or anything like that. I suspect that if we go this route, it will not be different from other institutions, and so there should probably be sort of a joint effort on the part of the hospitals that treat Ebola patients to communicate what the practices are. Let me ask you this: another issue that we may have to address is the question of whether people have a right to say no to caring for. Staff have a right to say no in caring for patients with Ebola. I'll leave that aside for right now because we haven't deliberated on that one at all yet, really. But if you volunteered, say, and you cared for a patient, and you were like one of those nurses in Texas, you then got the disease, would it be acceptable to you to recognize that the disease progressed to a certain point, that would be an automatic DNAR order for you?
While I'm healthy, I would say, yeah, I would be okay with that. But if I got it, I would change my mind. I may change my mind. But, yeah, but no, I mean, just sitting here and think about it, I would say, I think that's, I would like to say I want to do it that way now.
Right.
But even if I got it, I would think that would be the most appropriate way for me.
Well, the
to,
whole point of making a DNR is that it's futile. So
Yeah.
it would not be any less futile.
Right. It would not be any less futile, but the reason I ask it that way is that sometimes this brings it home.
Right.
What if this happens to me, but I still like the idea?
Because
As opposed to those patients who come in from outside and we're treating and we're doing the best that we can, and we see that it's futile. But to say it's going, in my case, after I just did this humanitarian thing of caring for other Ebola patients, you're not going to give me every last chance?
Like you say,
And the argument would have to be there is no last chance.
It has to be what I
That is
want
the last
something
chance.
futile to be done to me. That's the question. Most people say no to that.
I think it depends on what conversation I'll have. As a patient with the doctor that's taking care of me, that person tells me that it's futile, I would probably
Right, I mean, and it would, again, it would be above board presumably, you don't say, don't let somebody expect that they're going to have resuscitation attempted when they're not, you know, any of that sort. But just to, you know, you're healthy, you're young, not you, not me, the rest of it, healthy and young, and just thinking about ruling out because of the disease, and I think it should. That should be the policy, I think. But I think, you know, I just think I want to make sure that you recognize how it could hit home to a lot of people who aren't in the category of clearly dying before they contracted this disease or this phase of the disease, but this is what, you know. It's just a way of trying to make it more real, I guess. Okay, that's the end of my comments. Thank you.
Thank you.
Thank you for your help. I think that